Good afternoon, everyone, and welcome to today's webinar hosted by Region 8 chapters of HFMA. The topic for today's session is Integrate Revenue Cycle, Clinical Documentation, and Utilization Management. We are scheduled to run for 60 minutes today. For today's presentation, I would like to welcome our guest presenters, Megan Beasley, Megan Sorenson, and Blake Evans, all of CROWE HORWATH. Megan Sorenson is a senior advisor within CROWE's healthcare performance practice. She has nearly 4 years of healthcare experience focusing on charge capture, CDM, clinical denials, utilization management, and coding compliance. Megan is a certified professional medical auditor. And we also welcome Megan Beasley, who is a senior manager within CROWE's healthcare performance practice. She has more than 8 years of experience in the healthcare industry, focusing on charge capture and revenue integrity engagements in regards to data gathering, analysis and interpretation, process improvement initiatives, and formulating conclusions and recommendations for clients. She is a registered health information administrator, certified professional coder, and certified professional medical auditor. And finally, we'd like to welcome Blake Evans, who is also a senior manager and the revenue cycle operations leader within CROWE's healthcare performance practice based in Chicago. Blake has over 10 years of healthcare experience within several hospital systems, focusing primarily on patient access and other revenue cycle related roles. So without further delay, I'll hand the call over to our guest presenters. Blake, I believe you're up first.
I am. Thank you, Nikki. Good morning or good afternoon to some. Good morning to others. Again, my name is Blake Evans. It's our pleasure to present today, and we thank you all for joining the webinar. Just to give a brief overview of some of the key topics that we're going to talk about, is really to give a real overview of 3 real important departments as it relates to the finances of an organization. And really that's the revenue cycle, the clinical documentation improvement department, utilization, and utilization management. The other topic that we're going to talk about is really how does those 3 departments really intersect in a lot of ways, and really how do you align the responsibilities for those 3 departments. And then lastly, we're going to talk about how do you further integrate those departments. So just to start us off, just at a base level, I really want to just kind of talk through the revenue cycle and really align that with the patient continuum. And so when we think about the revenue cycle, there's really 3 specific areas. There's the front end of the revenue cycle, there's the middle of the revenue cycle, and then there's the back end of the revenue cycle. And really the front end of the revenue cycle really encompasses 3 main departments. It's really the scheduling, the pre-reg, the insurance verification, and the registration department. You know, the key things that are very, very important in that front end of the revenue cycle, and it really is a key area of the revenue cycle. It's almost the saying, garbage in, garbage out. So it's really important to make sure that data is very accurate as it relates to that initial part of the revenue cycle. That's really where a lot of the data entry happens. So making sure that the patient's insurance coverage and benefits are not only verified, but loaded in the system correctly. You also want to make sure that you have the appropriate authorizations and pre-certifications needed to actually bill out that claim at the time of billing. And then also, as it relates to the inpatient process, what we've seen in a lot of organizations is that the patient access staff has really taken the ownership of doing that initial notification of admission to most of the payers. And then you have the middle revenue cycle, and that's really where I call all the action happens in terms of the service that's provided to that patient. And so the 4 key departments as it relates to the middle of the revenue cycle is case management, utilization review, and sometimes you see those 2 departments kind of enclosed into one larger department, but sometimes it's separated out. There's also clinical documentation, making sure the physician and the clinicians are actually documenting things appropriately. And then lastly, the coding and transcription process. Really in that coding function is really the interpretation of the medical record and the documentation. And so if things are not documented appropriately, the coding team will sometimes miss those codes, and then also the charges won't be allocated to that account because it just wasn't documented in the record. And really, from a compliance standpoint, you have to make sure that those things are documented so you can bill it out appropriately. There's also the assignment of the necessary ICD-9, CPT codes, the DRG, and your HCPCS or your procedure codes. The other really important thing that goes on, especially in that utilization case management phase, is the concurrent and retrospective review of the admission process, really making sure that you have the appropriate status on the account. And we'll talk through that a little bit later in the presentation. And then lastly, once the patient leaves and it's time to discharge them and deprive them with a bill, is really what we call the back end of the revenue cycle. And it's really four key functions that's related to that. That's billing, collections, denial management, and then also customer service. The very first thing is really kind of getting that bill out the door. All those claims that are set in the unbilled status, that really gives the patient access folks and the middle revenue cycle team the opportunity to correct any errors before the claim goes out the door. And then once the bill has been labeled as kind of that final bill or sent out to a scrubber, it gives the billing team just another chance to check that account, make sure everything is on the account before it actually goes to the payer. And then lastly, once it gets to the payer, if the payer then in turn denies that account, what is the feedback mechanism back to the front and the middle of the revenue cycle to identify, why was this claim denied, and how do we go about correcting that in the future?
So, thanks, Blake. I'm going to dive into a little bit more about the CDI role within an organization. So really, the CDI facilitates the accurate representations of a patient's clinical status, as well as translates that into coded data. And they help facilitate that overall process. Really, the primary role of a CDI program is to accurately and concurrently review clinical documentation to ensure all elements are within the actual record. I would say that responsibilities for your typical CDIS really include the following. So they're reviewing the inpatient medical records, and in some cases we've seen the CDISs transfer into the observation or outpatient world as well. And they're looking for missing or incomplete documentation. They're really assigning and maintaining those working DRGs throughout the patient's stay. So it gives good insight into what's happening and how long that patient is potentially going to be here. It also creates a little bit of a collaboration with HIM, and it really should solicit that collaboration with that HIM, case management, and clinical teams to really promote that enhanced quality of care. And one of the other things that's super important as it relates to the CDIS is learning from what you're doing and what these people are spending time doing. So analyzing those patterns and trends that are in the clinical documentation to identify opportunities for improvement. Some of what we'll talk about a little bit later in the presentation is, how do we transfer the analysis of the data and the trending of the data into actionable items in terms of an education program that should be out there. Really, beyond just those obvious impacts, I think the four main areas that CDI really helps an organization is related to the medical necessity and ensuring that the medical necessity is in fact documented appropriately, compliance, monitoring that record to identify any possible compliance risks related to coding or documentation, as well as the quality of care, ensuring that all those comorbid conditions are clearly documented and accurately picked up. And lastly, which has become very important in the current structure of healthcare, is really understanding those PSI indicators and what do they affect from a quality perspective in those quality metrics that are reported out. With that, I'm going to turn it over to Megan Sorenson to talk a little bit about utilization management.
Thanks, Megan. So one of the main priorities of case management intervention is to support the patient to ensure that they're getting the best care and to achieve those positive clinical outcomes. The function of utilization management within case management is to make sure that that care provided to the patient is furnished at the appropriate level of care to help manage costs for the hospital. So utilization management's goal is not meant to limit or restrict the care provided, but to really ensure that the appropriate care is being furnished based on that patient's clinical condition. So medical necessity of care is usually reviewed based on evidence-based decision support criteria, such as either Milliman care guidelines or inter-qual criteria. And the utilization management department monitors the patient's stay preemptively, concurrently, and retrospectively. At the beginning of the patient's stay, utilization reviewers will work with the payer to obtain any required pre-authorization and approval for an inpatient stay that is required. Concurrently, utilization review nurses will continue to compare the patient's clinical indicators to the decision support criteria to determine if the patient is in the appropriate level of care. And if a change is needed, that UR nurse will work with the attending physicians to change the patient's level of care if necessary to avoid unnecessary consumption of resources. Care coordination, including discharge planning, is also provided while the patient is in-house. That retrospective review of medical necessity is also done, and utilization management will continue to work with the payer to provide any clinical information that is required or requested. An efficient utilization management department can help efficiently manage hospital resources, reduce length of stays, and avoid unnecessary denials. And Megan, if you can move to the next slide. I'll go into, along with coordinating the patient's care while they're in-house, utilization management will play a large role in the actual denial process, especially in relation to those clinical denials. There are multiple layers of the appeal process that utilization management will be involved in. Preemptively, reconsiderations after the initial denial happens while the patient's in-house. They can provide retro authorizations if applicable. They'll also work with scheduling and prepping the attending physician or physician advisor for the peer-to-peer process. If the denial is upheld or if the preemptive appeal process is not available, the provider will then move to that formal appeal process. Utilization management usually will house that denials department where written appeals will be submitted to the payer to contest the denial, and the provider should have tracking mechanisms in place to monitor any of those outstanding appeals for determination or lack of response. Utilization management should also have a good handle on the different requirements from each payer, whether that be from an authorization perspective or for their individual denial process, because it will differ payer to payer. And with that, I'll turn it back over to Blake Evans to start discussing kind of how we should be aligning these responsibilities through these main three departments.
Great. Thanks, Megan. You know, when we think about aligning the three departments that we just kind of reviewed, the revenue cycle, the clinical documentation improvement department, and then also utilization management, they really have separate and unique functions, but there is some overlap. And so, you know, one of the things that you continue to work within your organizations is really about getting that right alignment between those three departments to make sure that you're operating at a high functioning level. And so some of the ways you can align those responsibilities through education for providers, using the right dashboards and reporting, also doing ongoing DRG validation audits, really monitoring your length of stay, making sure that you have that physician advisor role, and really in alignment with that is making sure that you're doing the appropriate concurrent reviews and making sure that the utilization management team has really great communication with that physician advisor role. Really, there needs to be a high focus on clinical denials, and then also the patient status and authorization process, and then lastly, the payer communication and contracting. And so we're going to spend some time just kind of walking through how you can better integrate and align these three departments.
So to start off, we're gonna hit the ground strong with talking about an education program for providers. And many times this goes way beyond just the provider. And when you think about that education program, it should be facilitated by a physician advisor or a physician champion of sort. And in our experience in many organizations, that has been when we have found the most success out there. But one of the things that really should be looked at as this education program gets its feet is really utilizing those data analytics and trends to develop education needs for the organization. So maybe you look at some of your quality reports, or maybe you look at the way that things are being coded from a CDI perspective, and sepsis looks like it is an issue. Well, that should be at the top of the list of how are we going to educate our providers and how they should document related to a sepsis patient, and what does it mean now in terms of clinical indicators for sepsis itself. I think within that, again, develop those specific focus points on those documentation requirements. Provide that knowledge out to the team so that they can be successful, and really create some targeted education as well as reminders to those providers surrounding those needs. And including the most detailed summary of care being provided to the patient. So what do I mean by that? Give them some examples of what works and what works well and what has been successful and stood up. The last thing is, really basing additional education that's pushed out there on new CMS policies that are going to affect the clinical individuals within an organization, as well as guidelines and medical necessity buy-in. It is so important for everyone to understand and create a consolidated messaging out to the providers so that they can really enact change in the organization and take that messaging in and put it into action. One of the deterrents that we found in many organizations is that there's messaging coming from all of three of these areas. So utilization management is providing some information to the providers. Case management is providing some information related to the social work aspect of those patients. CDI is asking the providers to do X, Y, and Z. And then you're also getting some medical necessity validations from the revenue cycle. And what does this do if we're all coming at these providers in this capacity? They tune us out, and we can't enact change within the organization. So it's very important for everyone to get into the same funnel and really work to create that consolidated messaging so we're not confusing anyone and so that we can obtain buy-in within our site. And now we really want to get into the physician advisor role. So diving into that, Megan Sorenson, can you please take the physician advisor role?
Yep. So the role of the physician advisor has become increasingly more important within hospitals. The physician advisor is able to provide that direct communication line between revenue cycle, utilization management, and CDI to the medical staff. So we're really playing off of everything that Megan Beasley just went over. This advisor role is a great way to actually provide that communication down. So the physician advisor role itself is able to create synergies within the hospital staff and physicians. They should have an understanding of not only the patient quality of care and physician clinical documentation, but also have some bit of an understanding around the billing denial process and really be aware of where the facility is falling short. They should be utilized as an educational resource to the medical staff, especially for UM and CDI for that level of care placement and documentation deficiencies. But where they also play a really large role is in the denial process, especially surrounding the peer-to-peer process. What we've seen is really creating a successful peer-to-peer program is utilizing these physician advisors, not just to perform the peer-to-peers, but also to provide education to other physicians on successfully overturning peer-to-peers and advising in the formal peer process and really helping with that communication with the payers. This process is extremely important because many times the denials can then be overturned prior to the actual denial coming through on remit data, and so it can really speed up that denial process and help get the hospital paid much quicker. So having the successful physician advisor program that's utilized by all three departments can decrease final denial write-offs, result in a decrease in avoidable days and length of stay, and really improve clinical documentation across the board.
Great, thank you, Megan. So as we continue to look at how we can get better alignment, I think this is very similar to the physician communication strategy. It's really around payer communication. And so as we look at the three departments and you think about their roles as it relates to actual communication to payers, there is some alignment, or there could be some alignment in the way we approach our payers. And so when we look at UM and we look at untimely appeals or determinations, maybe the payer's not responding to your peer-to-peer request, or there may be deficiencies in the authorization process. Or you look at CDI, you have a monitoring of different clinical indicators by your payer mix. And then lastly, from a revenue cycle perspective, we all know there's a ton of communication back and forth with payers as it relates to either denials or contract management, or even just overall deficiencies that you see as it relates to that payer strategy. You know, it's really important that each department, even though they have their need to communicate with the payer, there honestly needs to be a coordinated effort around, you know, how do you approach that payer and how do you gain the best buy-in? You want to make sure that, you know, if you have a payer rep, that you want to align your communication strategy to make sure that you're getting buy-in or feedback from all three departments so you can go with one consistent message. You know, the other piece that's very important, especially as you relate to your contract negotiations from a managed care perspective, is really to have that reporting that we talked about for all three of those departments, so you can really have a viewpoint and understanding of how your payer may be performing or not performing, and really incorporate that into your managed care negotiation.
Thanks, Mike. And I can jump into kind of some more specifics on reporting and dashboards. So the use of reporting tools and dashboards can be utilized to provide visibility into the different departments and identify areas for improvement across the facility, especially facilities that are utilizing different systems and aren't all putting their notes or account activities into the same place. The utilization of reporting can help reduce duplication of work within these accounts being touched by multiple departments and really create that visibility on the work that's being done across the board. Some of the data that can be utilized to provide this reporting is the 835 remit data from the payer, any tracking done from the appeal process, such as clinical denials and DRG validation audits, length of stay by payer and provider, and metrics tracking observation percentages, and so on. This data can be utilized to identify specific issues, problem payers, and can also help monitor progress for process improvement initiatives that have already been put into place and make sure that they're continuing to work effectively. Also, making this reporting available to all units can help coordinate education efforts to make them more valuable and avoid duplication. And Megan, if you can go to the next slide with some more examples on some of these dashboards. Where this data is actually really able to drive that change is by compiling the reporting back to departments, and creating the awareness of any shortcomings or areas for improvement will keep the departments accountable for actually driving that process change through. We've included some examples on this slide and the previous slide of some data metrics and dashboards that can be utilized and we've seen utilized at our clients. However, these are really just the tip of the iceberg. There's so much information that is available across each facility, and being able to combine efforts to really understand what all this data means and how it can be applied is so important. So some of the examples that we've included on these slides are an HIM dashboard that has the ability to drive down and see which specific diagnoses are causing issues with either denials or extended length of stay. And the facility can identify this and deliver specific education to the providers on that care that should be provided for those diagnoses to help drive that improvement. Or tracking of denial performance metrics such as initial denial versus final write-off amount can provide insight into that success of the appeal process or program that's being utilized by the hospital. And with that, I'll turn it over to Megan Beasley to kind of talk about the length of stay monitoring.
So when we talk about length of stay monitoring, we're really talking about the combination and the power of utilization management and CDI coming together. So length of stay can really be used in a variety of ways, but mostly there are metrics out there that we can benchmark ourselves against. And monitoring and taking a look at this information and sharing it across the continuum from a clinical documentation as well as a utilization management perspective can not only help with our patients' quality of care as it relates to how long they're there, but also can help with that interfacing with the insurance company as you're a utilization management RN trying to get approval for more days, especially if more days are within the average length of stay or geometric length of stay for that particular patient. So really the coordination between CDI and UM can significantly improve average length of stay as well as overall patient quality. And what this will really also help drive is throughput. And throughput is so important to every organization that is out there. Making sure that the patients are accurately placed in the appropriate status or in the appropriate type of bed, and sharing this information as that working DRG gets created from a CDI perspective is so powerful for many organizations. Lastly, this can also help drive some additional information as it relates to your discharge process. So maybe we have a particular floor or a particular physician that always takes longer to discharge their patients. And we need to understand what's going on and why our throughput is not accurate as it relates to that outlier for that particular DRG. Now, it's not to say that every patient's going to fall within that geometric length of stay or the average length of stay that are posted, but they're able to be used as guidelines, and you can see where you fall on that spectrum overall as an organization. Here's some additional information, and this is what we typically recommend as you're looking at length of stay. Many of our clients elect to look at it from a quarterly basis because sometimes they may not have enough data to drive monthly change, and there could be outliers in there as it relates to a month. So we typically trend the data from a quarter perspective, but then look at it over a year's worth of time. Additionally, I mentioned that physician breakdown. So looking at those 5 highest physicians where they're outside of that average or geometric length of stay, and that variance is pretty high, especially when it pertains to their count being high. So if you have an orthopedic physician that is constantly keeping their patient 3+ more days than what is normal or what the other orthopods are keeping their patients, it's good to have this data to drive some initial conversations. Again, I mentioned by floor breakdown, so that can be important from a nursing perspective and understanding, how that particular floor acts and what type of patients are on that particular floor. Next, we're going to get into concurrent in-house reviews. And, utilization management and clinical documentation improvement, or the CDISs, are really the owners of those concurrent reviews that are happening of your patients that are in the bed. Utilization management tends to touch a little bit more, whether it be outpatients in a bed, whether it be observation patients, as well as those inpatients. Whereas CDIS tends to focus only on the inpatient side. However, I would say that we've seen a opening of CDISs moving into that observation status, that outpatient in a bed status. So looking for additional supporting documentation to maybe approve or push a patient to an inpatient level of care because they meet the medical necessity for it. But a documentation component was just lacking from the physician. So really, utilization management's role is to connect the provider, the payer, the patient, and validate that level of care and length of stay. Whereas the CDIS is looking for that supporting documentation improvement and connecting the provider to the medical record. And as you can see, these two components could really be powerful if they're working together. So you have one that's really primarily responsible for the payer piece of it and the level of care piece of it, and you have another that's really documentation focused. And if you combine those forces together, think about the patients that could be converting, or maybe we mitigate some of the denials because we have a patient that is inappropriately statused in an inpatient level of care, and we have contradicting documentation to support maybe having them in that observation level of care. With that, we're going to go into clinical denials, and Megan, I'll turn it over to you.
Thank you very much. So utilization management and revenue cycle should both be actively involved in the process of working these clinical denials. These denials will include denials of payment on the basis of medical necessity, length of stay, level of care, lack of authorization, and other clinically driven categories. As discussed previously in this presentation, utilization management will be actively working the appeal process if applicable, concurrently while the patient is in-house, and then retrospectively either pre or post-payment. Where utilization management and revenue cycle should be working together, not just to avoid duplication of work, but to also maximize efforts is in the monitoring of open appeals until resolution, and that follow-up and communication with the payer on the status of these appeals, and then also on reporting of denial trends. The reporting should be able to provide insight on reasons for denials, denials by payer, the favorable versus non-favorable resolutions, and facility-specific information such as physician and case manager working the account. It is crucial that both departments have visibility into the work that each other are doing to avoid duplication of work. This can become difficult, especially if utilization management is working out of different systems. We see a lot of our clients working out of MIDAS, and really that visibility is so important so that work steps aren't being done by both departments. Utilization management and revenue cycle can both help speed up this appeal process by following up with the payers, especially when these determinations are untimely on open appeals. However, this can be very time-consuming to be contacting the payer for a high volume of accounts. So communication of what has already been done from a follow-up perspective is really important to avoid that duplication of efforts and maximize the work being done from staff. So that active communication between the two departments and sharing of tools and tracking methods can help make this process so much more efficient. Combining the reporting can also help maximize education and process improvement efforts that the facility and physician advisors can focus on. With that, I'll turn it over to talk about authorization and patient status changes.
Thanks, Megan. You know, one of the things that we talked about in the beginning, Nikki did a great job of kind of sharing our background. You know, one of the things that we've had the benefit of doing, or me personally, is I've also, not only as a consultant, had the opportunity to work with these departments, but also from a actual operational leader perspective. Before joining consulting, I was actually an operational leader leading the patient access department for a couple of hospitals, and then in my work in consulting, I've actually had a chance to be an interim leader over the utilization management department. And so Megan has given a great example of how, you know, the utilization management and the revenue cycle can work together. I really want to focus it in on really two specific things, because these are really important in terms of reimbursement. And so as we look at the patient status process and then also the authorization process, there are really key roles from a patient access perspective, the process that it relates there, and really some things to look out for as leaders of your organization, and how do you make sure these departments are lining appropriately. And so as we focus on patient status and we look at the patient access area, in a lot of organizations that we've seen, you know, the patient access department or registration department is really responsible for putting in that initial patient status from the ED, because you have different ways the patient can be admitted. So you can have them as a direct admit from a physician office, or inpatient from a surgery account, or actually admitted from the ED. And so typically what happens is once that patient is admitted and the appropriate status is determined that the patient is going to be admitted, it's typically that registrar that's putting in that status in the system. And so, you know, right off the bat, if they document that status inappropriately, then it'll cause issues long-term in terms of getting that account approved, making sure they're in observation inpatient appropriately. You know, a lot of times from a registration perspective or a patient access perspective, it's really all about the accuracy of data entry. And so one of the things that you may want to watch out for as you look at your organization is just maybe just doing an audit of maybe what was the initial status that was communicated to the patient or communicated to the patient access rep, and what was actually entered into the system. Many times there's no initial admission order, especially during that ED transfer process. So you want to make sure you have some documentation to understand, you know, what does the clinician tell that patient access rep to enter in the system, and then did they enter that information correctly? And how does that relate to utilization review? You know, you think about the role of utilization review, they're really responsible for verifying that status, that first initial status of the patient, whether that be observation or inpatient. They're really responsible for that. And then they're also responsible to make sure that that aligns with the physician order. And if you're like some of the organizations that we've been to, sometimes that physician order is still not there, even once the utilization review rep starts to look at that account. So it's really up to them to contact the physician and say, hey, you know, we saw this patient was admitted, we still don't have an order. Can we get a status on that? We want to validate, making sure that you use the appropriate criteria to validate which status that patient should be in. And typically what we've seen in the market, or as we work with our clients, is really three main ways that people are validating that. It's through the Milliman criteria. Some organizations use interqual. And then some organizations are really reverting to the 2-midnight rule to really just understand at a base level whether their patient should be observation or inpatient. You know, one of the things that you want to really make sure for appropriate compliance and payment is that you actually have a signed physician order. So, you know, the electronic order can be out in the EMR in the system, but you want to make sure that that has an electronic signature from a physician. And for those organizations who may still be on paper, you want to make sure that you have a written order that's, you know, signed and scanned into your medical record. As we look at the authorization process, these two departments, they really, have to play nicely in order to make this all coordinated. So really at the time of patient access, that group is really responsible for validating and entering, loading accurate information. And one of the more important areas is the insurance information, making sure that you load Blue Cross PPO versus Blue Cross HMO, and you load it, Blue Cross versus Aetna, and making sure that information is loaded correctly in the system, because that really is the basis for what that utilization and review nurse is going to use to actually validate and verify the information. And so the things to really monitor there, and really the patient access department is also responsible for, in some organizations that we work with, is actually doing that initial notification of admission. That may vary to your organization, but most times in the market we've seen the patient access department be responsible for actually contacting the insurance company and saying, hey, your patient was admitted to our organization or to our hospital. And so things to monitor is, here again, just incorrect information, making sure you load that in correctly. And then a lot of the payers, they have requirements to make sure you do that notification within a 24-hour period. So you want to make sure that you have a process in place from a patient access perspective, if that's the owning department, to make sure that that notification is done within that 24 hours. From the utilization review perspective, really doing that concurrent and retrospective review. And you think about how these two departments play out. If I loaded the wrong insurance and I go to try to do a concurrent review, I'm going to contact the wrong payer, and I'm going to waste a lot of time contacting that payer for them to only tell me, hey, we don't even have this patient on file. So it's really important to have that information entered into the system correctly the first time. And then also, most times payers will use that skeleton off that you'll get at the time of that initial notification to actually get the further authorization approved. So they'll ask you for what was the skeleton off, or what was the authorization you received when you did the notification. And the utilization department utilizes that information to actually get the full authorization as they go through that concurrent review process. And then also making sure that they document that authorization in the PAS system, or making sure that it aligns with billing. So that actual authorization number, it actually is going to have to go on the claim at the end of the day. So making sure that you enter that information in correctly. Things to monitor, just having the incorrect patient status from the admitting source. So a lot of times when patients are admitted from the ED, the clinicians may not know exactly which status that patient should be, but you want to make sure that as you're going through your criteria review or bumping it up against Milliman or NFR or the 2-midnight rule, that you're placing that patient in the bed appropriately, and then also making sure that aligns with the physician order. And then also contacting the payer for concurrent review prior to the notification of admission. So a lot of times if you don't have a coordinated effort, the utilization review nurse will contact the payer, and the payer will say, well, I didn't even know your patient was admitted. So you have to make sure that there's some sequencing in the process. The patient access, or whichever department is responsible for that process, does the notification, and then the utilization review utilizes that information to then get secure the rest of the authorization to complete the concurrent review process.
Thanks, Blake. I'll take it from here. So a topic that's very, very hot right now is related to DRG validation audits. And most of the time, these are really coming back to our organization in the form of an audit. But however, we have seen an influx of those RAC organizations utilizing and pinpointing these DRG validation components to look at, did we code the accurate DRG or come to a consensus for that accurate DRG? Really, DRG validation audits break down into two components. The first is that DRG validation. So do we have all the right ICD-10 procedure or diagnosis codes that's going to contribute to our DRG on for the patient's account based off of the documentation? Secondly, which is, in my opinion, a lot more apparent for our clients, is this clinical validation piece. We're seeing a lot of the payers catch on to these clinical indicators and are pushing for almost their own set of clinical indicators for different things like sepsis or different items as it relates to infections, infection control, acute respiratory distress or acute respiratory failure. So as it relates to that clinical validation piece, really the name of the game is, does that medical record justify that the patient actually possessed those conditions that were in fact not only documented, but there were indicators, whether it be lab testing, other testing of sorts, that support that documentation from the provider. And one of the things that is so important in that clinical validation space that we've seen time and time again is to really control those progress notes as well as those H&Ps and discharge summaries, and making sure that our providers are not just copying it forward for their daily progress notes that's out there. Because we found that there's been very many contradictions in those documentation components when things are just copy and pasted forward and items are not addressed to be changed. And really, CDI should play a very large role in monitoring that component, as well coupled with that physician advisor to drive some change with the organization to hopefully not allow them to copy and paste progress notes forward. I will say that these audits can be very complicated, as I mentioned, due to the different types of clinical indicators that are coming from payers. An example of this is I've recently seen that United has their own set of clinical indicators that they're trying to push through as it relates to the count of white blood cells in relation to sepsis. So they're not following the standard clinical indicators as put forth by the NIH or other bodies like that. And so really when you talk about these audits, how do we manage them, right? Because there's so many ways that these things come to our organization. They may come through snail mail, and they go to 12 different people in the organization, depending upon what person or the address that that particular payer or body that's doing the auditing has. And the majority of the time, they're not coming through in terms of a denial, unless it's a RAC audit that is coming through and they're then wanting their money back. And that's the only cue that there's possible issues as it relates to these audits. And that's true for the other payers as well. But really successful management of these is really that coordination between that revenue cycle and the CDI team, and specifically the denials management team. They should really be involved in this auditing process. We have seen compliance as well get involved in these particular events. So I would really encourage those that are on the line to look at your organization and understand how you're receiving these types of audits and what is the magnitude of these types of audits. In some cases, we've seen them just be held by HIM, and they have only looked at the account from a coding perspective, but again, that doesn't get at that clinical indicator piece to truly fight the appeal. So are you accurately and appropriately putting together a statement that is stating your case for that particular DRG? And when we look at a lot of these, because a lot of these DRG changes are moving us from a MCC to a CC, and there is a large dollar amount that is related to these takebacks. So understand how you're receiving the information, coordinating that appeal process. So you know, understanding at every step of the way where that account is in the appeal process. Are we at first level? Are we at second level? What are we going to do if we got to second level? Is there a structure in place where there's escalation and review of the account in terms of, are we looking for clinical indicators, or did we just not get the coding accurate? And then inversely, and one of the things that's most important around these DRG validation audits is gathering that data and trending it and understanding where we can improve. So if we're admitting defeat because we didn't meet the requirements of the documentation, then providing that feedback down to the front line, whether it be a provider, as I mentioned in those progress notes, H&P, discharge summaries, whether it even be to maybe some nurses that created some contradiction within the record itself, and that's what the payer latched onto. It's really important to, again, share that knowledge, trend it, and then educate from there. With that being said, we're going to move into the integration of departments. And first, I'm going to turn it over to Megan Sorenson to get us started.
Thanks, Megan. So something that we've seen be extremely beneficial in breaking down these silos between the three departments has been as simple as just creating a revenue integrity oversight committee. So this provides an official team and structure to help create these synergies across utilization management, revenue cycle, and CDI, and really gives them that communication loop to bring up any issues or problems that they're seeing, whether it be within the facility or with payer, anything, kind of just having that time set aside for everyone to bring up what they're doing just creates that communication. So this group can provide a platform for all departments to share reporting, help pinpoint education needs for the physician advisor program or any other staff really within the hospital, and provide the group to bring up any issues that each of the individual departments might be seeing, and have kind of a team to help problem solve and find solutions and ways to push through that change. So having this open communication loop, we've seen it be handled either with monthly or quarterly meetings, can provide a lot of visibility into each department. Not only from pushing through change across the facility, it can also create accountability within these 3 departments. So if reporting is showing that maybe one of these 3, whether it be utilization management, revenue cycle, CDI, is maybe underperforming or not hitting the improvement metrics that have been kind of set for them, that it just kind of creates that accountability to make sure that that process change is actually happening. And if not, then they can discuss why and find opportunities to help improve. So what we see presented at these meetings tends to be denial data, audit results, trending, length of stay metrics, a lot of conversations around payer management are great things for this committee to review to help identify those areas to centralize education efforts, and just to identify common issues that are occurring with certain payers and any opportunities for process improvement, not only within the clinical departments, but also, as I said, these main 3 departments themselves. So we've seen these types of groups make a huge difference in breaking down silos within the hospital, and it's really just simply through creating communication and having each of the departments be informed across the board. And I'll turn it over for some additional strategies for aligning departments.
Yeah, thanks so much, Megan. And I think, this is a nice summary slide. As we talked about the 3 departments, we talked about, what are their roles and responsibilities, how can you get more alignment and more integration. It's really the key framework for revenue integrity. So you hear a lot of organizations talking through the revenue integrity functions and, really talking through, what that role stands for. And some of you in your organizations, you may have a designated role for revenue integrity, and some of them, you may have these different departments kind of all working in silos. And so the goal of our presentation today was just to give you some thoughts on how you can see more alignment and really just more structure around what that function should look like. And so as we talked about, what's the flow of the overall revenue cycle when you talk about the front end of the patient access and what their responsibilities are, utilization review, CDI, and then also just the billing, patient financial services structure. We want to just leave you with just some key strategies from the presentation, just to think through for your organization that we've seen be just a list of best practice things. So one is just to have accurate data. There's a lot of work that's going on in the healthcare industry right now just around big data, not only on the revenue cycle and finance side, but really more so with the clinical side. And so what we've seen a lot of organizations as we work with our clients is that when we're able to align those 2, both the clinical and the financial, we're just seeing significant results in performance overall for those clients that we work with. The other thing is to, make sure you find the right criteria. And what does that mean? So we talked about the 3 kind of criteria to check for status, Milliman, interqual, and 2-midnight rule. What we say is as best practice, you'll have some payers that'll use one criteria versus the other. You want to align your criteria strategy actually with your payers. So look at your top payers and really just try to make sure that you align your criteria with how they're statusing patients. 3 is communication. One thing in healthcare, we all have a tendency to kind of focus on patient care overall, but we get in our silos and we kind of put our heads down and just work on our part of it. And it's really, as we talked about, the physician education, the reporting, the payer communication strategy, it's really important that you communicate on a number of fronts. And so one thing, as we talked about those 3 departments, you may want to think about incorporating just some monthly or routine meetings with a set agenda to make sure that you're kind of looking at performance holistic versus just your own individual department. And then the last tip or strategy that we give is just kind of really focus on the clinical denials. I think that's really where the rubber meets the road in terms of performance and reimbursement. So as you look at claims that are being denied, not only for like authorizations and more what we consider technical denials, you want to look at the things that are attributing to more clinical denials. So things that are related to coding or things that are related to CDI or misdocumentation or requests for additional information, and really put a structure in place that not only you provide that feedback back to the departments, but then also you see performance over the extent of time. And so with that, I think that's all the slides we had. And we just want to just take this time to say thank you so much for participating in the webinar today. Nikki, we'll turn it back over to you.
Perfect. What a great collaboration. Thanks, guys, for such a valuable presentation. Before I take our first question, I would like to remind everyone to type their questions into the question chat panel, which is located to the right of your screen, and we'll take as many as time will allow. I will address one question about accessing the replay, so you don't have to wait. You can gain access to that right now. Again, on that right-hand side of your screen in that floating panel, you should see a section called Handouts. Just press that right arrow button so it's facing down. That expands it, and you'll see the PDF icon that you can click on and get access to these great slides right now. All right, so we've had some great questions to come in. I'm going to tack the most detailed one first. This one comes from Angie, so bear with me as I read this off. It reads, we continue to have claims denied because drug NDCs, because payers do not have the NDC used on the payer's internal approved list. We have determined that the approved list is connected with the manufacturer's rebate program. From a documentation and utilization review standpoint, our staff has confirmed we are using the correct NDC for the drugs given. We are not getting reimbursed, and it, as you can understand, is affecting our revenue cycle tremendously because the denials are piling up. Have either of you seen this within other facilities? And if so, could you speak to how they are handling it?
Sure. Thanks, Nikki. I have seen it only in a few organizations where this has come up, and it was merely a miscommunication on the NDC list. So I would highly suggest getting a contact with that particular payer to talk through those particular drugs and NDC numbers. I've also seen it elsewhere where the drugs were truly being utilized for a replacement program purpose, and it was inappropriate for the organization to, in fact, bill the payer for that particular drug and setup of that drug. So I would, one, start with the payer, and one of the things we hint on in the presentation was around payer communication and making sure that you have those contacts within the payer side as well, especially for your large payers that are contributing majorly to your bottom line. And I would really take a lens beyond the revenue cycle, but having a lens of a clinical interpretation from a payer perspective, and that utilization management team should really work to forge those relationships with those payer contacts. And I've seen success being contributed once that relationship has been solidified or a contact was made.
Yeah, Megan, one additional thought I would add is that, you know, as you go to the payer, and I agree wholeheartedly with that strategy around going to the payer, it's really just having the right data to support your messaging, right? So obviously you guys are tracking the denials as a part of your organization and how much of a dollar impact that's impacting your organization. So I would just reiterate, make sure you bring that data to that meeting, as well as any kind of clinical examples that you can share to say, hey, here's what we documented this drug code, or, you know, here's where it is in the system, and here's what your list is. And, you know, from our perspective, it matches. So you have to walk us through, you know, where the breakdown is. So that would be our recommendation.
Okay, perfect. Looks like we have time for at least one more. This one comes from Susan. In your slide deck, you talked a little bit about the criteria. So she's looking to clarify, is it your suggestion to maintain contracts with both interqual, as well as MCG?
No, usually what we see, sorry, go ahead, Megan.
Thanks. So I would say the majority of time of what we see is to go with one or the other and utilize that criteria set to drive decision making, or help guide what that utilization management is going to, or utilization management RN is going to do in terms of patient status. But again, remember that this is only a guide, and that there are outstanding circumstances and additional clinical indicators or additional pathways that the patient may be treated for that's outside of scope of interqual or MCG and are not accounted for clinically in those examples, especially when you talk about patients that have a lot of comorbid conditions, and those things just pile up. When you talk about utilizing the criteria set, you're really, again, utilizing it as a guide to the best of your ability. So one thing that I would also add is utilize the 2-midnight rule for Medicare and Medicare HMO, and really hold your Medicare Advantage and your Medicare HMO to that standard that CMS has put out there, because we've seen it across the board where that hasn't happened, and there's been severe dollars that have been left on the table. Megan, did you have anything else to add to that?
One thing I would add in is what we tend to recommend looking at different hospitals is really look at what your main payers are utilizing for their review, because especially even from just a peer-to-peer process, if they're looking at the same criteria, it tends to, I think, help with the overturning of any denials that you're getting. So I think having those conversations with the context at your main payers can be extremely beneficial when trying to decide what criteria set to go with.
All right. Okay, so let's go ahead and wrap it up. I apologize, we're already a minute over, but I do want to just take this very brief time to thank our members in the healthcare community for joining this call. Region 8 HFMA does have another webinar installment scheduled for December 19th at the same time, so be sure to keep an eye out for session and registration details. Also note you will be automatically routed to a survey at the end of today's webinar, so be sure to share your thoughts and provide the email addresses of everyone in the room to ensure they receive proper credit. So thank you again to our guest speakers, Megan Beasley, Megan Sorenson, as well as Blake Evans, all of CROWE HORWATH. We really appreciate you taking the time to craft your presentation. I know that's a tall task, so thank you on behalf of HFMA and the healthcare community. Guys?
Thank you. It was our pleasure.
Thank you. Okay, so have a great afternoon, everyone, and we look forward to seeing you online in the near future.